Welcome, everybody. We're excited to have you here for our second 2025 Professional Learning Series. Very happy to have Dr. Mark Gormley from Gillette Children's here to present to us on a great topic on cerebral palsy. I just want to make some reminders before we get started. First of all, we will not be having any questions during the presentation, but we will have Q&A afterwards. The meeting is being recorded, and you will get the recording afterwards as well too. Also, there will be a survey that will come out after this, and we're asking you to provide us any thoughts, feedback. It really makes a difference when it comes to planning the different learning series that especially as we start to move towards making some choices for 2026. So also, just so you know, we have two more yet this year, both in September, which is on the on-time framework for mobility, as well as later in the year, I believe it's late November, for a session on coaching. So I want to introduce to you today a really great friend of mine, Dr. Mark Gormley. He is a pediatric rehabilitation and medicine physician at Gillette Children's, as I mentioned. And he is also on the board of trustees at United Cerebral Palsy, our national office. But how I know Mark best is he is the liaison for the United Cerebral Palsy Research Council. And I would tell you that he is more than just the liaison. He is a partner in some of the much of the projects that we work on. He's integral to everything we really do. And he brings his expertise in cerebral palsy as well as his passion as well too. My favorite story about Mark is when I first met him, he got on the phone and talked for about 10 minutes straight about a child and how he was so excited with the outcomes related to constraint-induced movement therapy. And I was trying to catch a plane, and that was a foreshadowing of the planes that I've almost always missed because we get into discussions. So anyhow, I'm very excited. Mark's going to be presenting on confusing outcome studies and controversies in cerebral palsy. I know you will enjoy it as much as I do. And let's get started. I'm going to turn it over to you, Mark.
All right. Thank you, Valerie. And I will also say that Valerie is actually the driver behind all that work at UCP and the Research Council. And if it wasn't for her, none of that would get done. It's been a lot of really good work and progress over the last few years. So, Valerie, we all thank you for that. All right. So I'm going to be talking about this talk. When I was putting together this talk, it went through about 4 or 5 different titles. And so and the one I finally landed on was Treatment Controversies in Cerebral Palsy, Navigating the Literature. But reflecting back on it, I probably should have said Navigating the Literature with a little bit of Treatment Controversies in Cerebral Palsy. So I was going through this, and I kind of already knew this anyways, but when you put together, putting together a talk, I'm trying to get all the different evidence and different things that's out there. And it ends up that for cerebral palsy, there's not a lot of great evidence. There's a lot of evidence out there, but not a lot of great evidence. And that's because of the heterogeneity of dealing with cerebral palsy. And it's really difficult to do studies. And it's really difficult to do very, very high-end studies to show a definitive proof of one thing or another. When we're doing this work, it's not always necessary. And I want to illustrate that as well. And so I'm going to talk mostly about literature and navigating and how you come about looking at it and trying to critique it to see whether it's useful information or not. I think that I can tell you the way I do it. I think most people do. When you see a study that's in the literature, what you do first is you look at you look at the title. Okay, so you look at the title and go, oh, okay, that's just something I'd be interested in looking at. And if the title is very descriptive and it kind of fits your bias or what your feelings are, you may not even look to it anymore. It goes, oh, it's one more study, great, that proves what I think is right. And if you have a little more interest for whatever reason, you look at the conclusion. If the conclusion is meets your narrative, and then you may stop there. And then if you really want to look into it, you'll you'll read the whole abstract and kind of figure out from there. And if you really, really want to look at more information, you'll read the whole paper. And I think most people don't do that, but there's the people that do that. And what you find is that there's evidence that's buried into all of these papers, and you can tease out, even no matter how objective somebody wants to be. And I'm going to show you some studies that I was involved in which I thought I was super objective, but it's obvious there's a whole lot of subjectivity that's involved in that. No matter how hard you try, there are nuggets of subjectivity in every study. And then so you've got to kind of take that with a grain of salt. And even if a study doesn't show a huge amount of significance, a lot of people equate that it proves the negative, but it doesn't. It just proves that study just shows that it didn't have enough evidence to prove what it was trying to prove because it didn't reach significance. It doesn't mean the opposite is true. Sometimes it does, but not always. So you've got to be careful about that as well. All right. So with that preamble, we'll move on to the slides. And so when you're looking at the types of studies, there are certain studies that have a higher level of evidence or scientific vigor than other studies. And the top of that is what we call systematic reviews. And if anybody's looked at the reports, that's basically a magazine that comes out, a journal that comes out with systematic reviews. And they do a very, very good job. And I will caution you, if you look at the Cochrane reviews, they do a very good job of looking at systematic reviews. But
your slides aren't showing. I don't think we don't see your
slides aren't showing. Am I not sharing?
Yeah.
Oh, well, you should have stopped me before then.
Well, okay. I thought it was my view.
No. Okay. Hold on. I thought we had this all figured.
To all of you that are on, we worked on this very hard. Here you go.
They're showing now?
Yes, but I do see your notes, but I don't think that actually matters.
I was wondering because the window was a lot bigger. The whole Zoom window was a lot bigger. I thought that's weird. All right, it's showing. All right, you're seeing treatment controversies in cerebral palsy, navigating the literature.
Yes,
Dr. Gormley, why don't you just hit the display settings and switch the views again, and then we'll get it. Sorry.
Display settings. Switch the views. What
Yep,
are you seeing my notes, or are you
We're-
seeing the other one?
We're seeing your notes.
Okay. All right.
Yep, right there.
Okay. All right. So are you seeing just one slide now?
It's still a notes view, but I think we should just move forward.
Yeah,
Oh,
I
no.
agree. I can see them really well. I bet everybody else can.
All right. Well, that's too bad because I got a lot of punchlines that come up on these notes view. Y'all gonna see. I can't
Of course you do.
set you up ahead of time. Okay. All right. We'll work with it anyways. Okay. All right. So if you systematic reviews. So if you look at the Cochrane Journal, it has systematic reviews, and it's a really, really hard standard to meet. And so you get studies that have a high level of evidence, and their levels are so high that if you read it, it'll sound like they think it's nonsense, but in reality, it's not. And so they to really get to meet their standards of being pretty substantial, it's a really high bar. So there's a lot of really good studies out there that they may sound like they don't reach that criteria. The studies that most people think about as being the high level is what we call a randomized controlled trial. And so typically what that is it's a prospective study. And so that's a study where you plan and you make a plan ahead of time. And so you figure out what your questions are going to be, what data you're going to gather. And you don't go back and cherry pick the data afterwards. You figure out ahead of time what your data is going to be. And then oftentimes we'll have, and ideally you have what's double-blinded. Sometimes they have what's called triple-blinded. But you have a double-blinded, which means that the patient and their family, as well as the whoever is conducting the study, the provider, whether it be a physician, therapist, or otherwise, are all blinded to whether they're getting a real treatment or a sham treatment. Now, you think about drug trials would be a placebo, and I'm going to talk about a couple of those in just the next slide. But double-blinded studies that are prospective and then randomized. So you don't pick like a certain group of patients that are going to go into the placebo branch and another ones that's going into the real treatment branch. you randomize them, and you try to make it so that randomization is fairly equal, and that you're not heavy weighting on one side or the other. And then, like I said, it's a placebo-controlled trial, so you have a sham treatment. And then marching down on that, you can have non-randomized controlled trials. You can have case-controlled trials, whereas, for example, you can be looking at, if you're trying to figure out if in a certain population smoking is associated with lung cancer. Now, if you were to do a randomized prospective double-blind placebo-controlled trial, you would give everybody a pack of cigarettes a day. One pack would be real cigarettes. The other pack would be just benign candy. And you would start them at 16 years of age, and you'd have them smoke a pack a day, and then you would see it, after 50 years, how many of them got cancer and how many of them didn't. Now, obviously, that you wouldn't do that. And so, doing a randomized controlled trial to see if smoking is related to cancer is not realistic. And so, if someone says you have to do a study and I don't believe you unless it's a randomized controlled trial, where there's so many things we do in medicine you're never going to prove because that bar is too high. And I'm going to show you a couple of examples of that later as well. And so case-controlled trials and non-randomized controlled trials have a higher degree of evidence as long as you design them very vigorously. And then retrospective chart reviews, where you go back and you look at a group of patients and see there's associations between what you're seeing and in some type of intervention. And then there's a case series where you get a number of patients that have kind of something similar that's going on, and then you look at all the specific details of that group of patients, and you individually pull them out to see if there's some commonalities that would be educational. And then the lowest level would be opinion paper, and I've been involved in a couple of those. And basically, it's just a bunch of people sitting around just giving their opinions, and we write it up. It does provide some insight. But it doesn't reach a high degree of scientific rigor. All right. So I'm going to show you a couple studies that I was involved in, 3 exactly. And this is the reason why you always do a placebo-controlled trial if you're doing a drug trial, is because a placebo always works. And so if you are to look, let me see, we're in the notes. Can you see my cursor? Is it moving on the notes? Or no?
It is. It is,
Oh,
Mark.
it is. Okay, great. All right. So if you look at, these are 2 studies. This is onabotulinum, which is Botox, and this is avobotulinum, which is Dysport. They're 2 botulinum toxins. They're very, very similar. And these are all in children with cerebral palsy. And so we had 3 branches. All of these, we had 3 branches of treatment. Now, in the avobotulinum study, we had a very, very low dose, which was considered the placebo. And then we had a medium dose and a high dose. And then in the onabotulinum, we had nothing. So we had truly no dose. It was a true placebo. And then we had 2 other doses. We had, for the upper extremities, it was 3 units per kilogram and 6 units per kilogram. And for the lower extremities, 4 units per kilogram and 8 units per kilogram. I'm not going to get into details of all of that. But what I want you to see is that in these studies, you're trying to decrease what's called the modified Ashworth scale, or the level of spasticity or the muscle tightness. And it's a scale that we use for those who are not familiar with it. And downward is improvement. And so you want it to go down. You want it to get less because you want that tone to get less. If you just looked at the placebo, here's where they all started. If you looked at just the placebo, it goes down significantly. And if you did a statistical analysis on what their baseline was versus placebo, the placebo worked. And so just injecting saline into these muscles significantly reduces their spasticity. And we're trying to see whether the medication itself worked. If the FDA was to look at this study, that's why they want a placebo, because if we did just a placebo, the FDA would approve placebo just for spasticity management, and we know that that's not true. However, in these studies, what we found is that the real stuff, whether it be the 3 and 6 in this study, or if this one over here, where it's the 4 and 8, they were significantly lower in their spasticity scales than the placebo. So the difference between this line and these 2 lines were significantly different. And so the line between the low dose or the medium dose and the high dose really wasn't that much different, because you can see that they're really kind of you can trace them all along. But the placebo is a little bit up. That difference was enough to be significant and enough for the FDA to approve Botox for kids with spasticity. And similarly, Dysport, or abobotulinum toxin, had a similar effect. The placebo worked. And then in this study with the abobotulinum, when we presented it, we had a 63% response rate for the placebo, which would be statistically significant. And we had a study that was on bookend on both sides of the studies, looking at treatment with botulinum toxin and the real stuff. It was an open label. One of them came back with 61% efficacy, and the other one was 62% efficacy. And if you were to look just at that, those studies, they concluded that was statistically significant. Actuality, the placebo worked better. Different study, but the placebo worked better in our study. So the facilitator for it said, well, why don't we just inject placebo, because it seems like it works better than the real stuff. But in these studies, the real stuff actually did work better, and it was statistically significant enough that it was considered enough by the FDA to approve these medications. Now, here's my favorite part of it, is that conventional wisdom is botulinum toxins last about 12 weeks. And the duration of these studies when we followed this was 12 weeks, and it wears off after about 3 months. And so if you follow the real stuff, you see that the curve goes down, the spasticity gets better, and after 12 weeks, it wears off like it's supposed to. Well, if you look at the placebo, it gets better, and after 12 weeks, it wears off. So even the placebo wears off. So that tells you your internal bias, and I was part of all these studies, my internal bias told me it should wear off in 12 weeks. Now, I hope I'm not part of this placebo. I hope I didn't think it worked that well, but I don't know because I was blinded. But it just tells you how significant placebo effect is. And that's why you always do a placebo trial, because it always works. And you try to compare it against the real stuff. And if you don't see a difference, then it really probably is not that effective, at least for that study. All right, so that's why you do that. Now, when we looked at randomized controlled trials, you remember I said before that a lot of the patients that we see with cerebral palsy, the heterogeneity makes it very, very difficult to do trials. And if you were to do a cancer trial, and you wouldn't be given half the population cigarettes and the other half without, and follow them over years to see what happens. And so similarly, there was a group that published this study back in 2003 in the British Medical Journal. So this is one of the highest end medical journals in the world, about parachutes. This is that parachutes, they wanted to know whether parachutes worked, and there had not been a systematic review. And they did a systematic review, the highest level of study, to look at randomized controlled trials for parachute use. And what they found was there wasn't any trials. And so they said parachutes, what they concluded was parachutes are widely used to prevent death and major injury after gravitational challenge. Parachute use is associated with adverse effects due to failure of the intervention or iatrogenic injury. So either you can get injuries if you don't use a parachute, and injuries if you do. There's no randomized controlled trials of the parachute. So what they concluded is there's really not any good evidence that parachutes actually work. But their ultimate conclusion is that anybody that says you have to have a randomized controlled trial for everything, it needs to come down to earth with a bump. So basically, this was a tongue-in-cheek article. It was published in the British Medical Journal. But what they were trying to illustrate is that a randomized controlled trial is not the be-all and end-all. You can get some really good scientific evidence of efficacy looking at other studies, but you just have to have it rigorously controlled as best that you can when you're doing that. And the collection of various different studies hopefully will come to some commonality. Okay. Now, there was another group that looked at that study and said, well, we're going to do a randomized controlled trial. So they actually conducted a randomized controlled trial to see if parachute use prevented death and major trauma when jumping from an aircraft. And they did it right because they learned how to spell randomized, which if you look back here, originally they didn't spell randomized right. So they spelled randomized right. So what they did was they designed a study over a year's time frame, and they had a group was assigned to have parachutes, another group was assigned not to have parachutes, and then they're going to jump from an aircraft. And this study was an airplane. So there's 92 people 18 over were screened. 20 of them actually agreed to be enrolled in randomized. I'm not sure how they get the 23, but they did. And they were given a backpack. Some had empty backpack, and some had a backpack with a parachute in it. But what they found is when they did the study is that as the groups, they were jumped out of the airplane, jumped from the airplane, that there was no difference in the injury. Nobody got any more injured with a parachute versus without a parachute. And they have all the different statistics here and reach a very statistical significance. However, the caveat is that they couldn't get anybody to jump out of 10,000 feet. They could only jump for 2 feet off of Bachman. And so they did a very well-controlled trial with a placebo and found that jumping from an airplane really, with or without a parachute, doesn't make any difference. But the caveat is it has to be from 2 feet. And so again, when you look at studies, you got to look at these details, because on the surface, if you read just the conclusion of this study, you would find that there's parachutes don't prevent deaths any more than jumping without one. All right, next, p-value. So, and that I just put those in there just to illustrate how effective placebo is, and also how even though you do a placebo-controlled trial, you can do other studies that are very high value, and you don't always have to do a placebo-controlled trial, depending on the complexities that you have to deal with, and CP is one of them. All right, so p-value. So you may hear, when you look at studies, you hear the people talk about p-value quite a bit, and all it is a probability. It's just a percentage of likelihood. And so if you're looking at a study, and I use the example of whether smoking causes cancer or not, the null hypothesis, if your hypothesis is that smoking causes cancer, the null hypothesis is that there's no association with smoking and cancer. You want to be really, really sure if that it is associated with smoking. And so the criteria that scientific studies have is a p-value, you'll hear this thrown around, a p-value of less than 0.05. All that means is that there's a 95% chance that this is real, and it's not a spurious relationship, that it is a real relationship. Now, it's not 100% to meet that criteria, but to meet what we call significant, it needs to be 95% or a p-value of less than 0.05, which means there's only a 5% chance that it is chance. So what that means is if you get a p-value of a study that's 0.06, you'll hear people say, "Oh, see, I told you that wasn't associated." All that means is that there's a 94% chance that it's real, and only 6% chance that it's a spurious or not related or not associated. And because our criteria is so high, it didn't reach that 95%. That doesn't mean it's not associated. It just means in that particular study, it didn't hit the significant point, which is a p-value of less than 0.05. And so you just got to be careful when you look at that. So I always look, when I look at studies, I look what the p-value is. And if it's 0.06 or 0.1, I'm going, okay, it's pretty good. We can't say for sure, but it's fairly decent evidence that there is an association. It just didn't reach the significance. But again, I caution, don't assume the opposite if that p-value doesn't reach 0.05, because all it is just a probability. Okay. And we already talked about all studies do contain bias. We all have biases, and that's why we try to reach that criteria of 95%. The results are only as good as the data and how you analyze it. And all data can be interpreted in different ways. And you can manipulate data, and I've seen people do it in studies a lot. And I try not to do it myself, but I can't say that unconsciously I don't do it. But you can manipulate data to meet your narrative fairly easily, actually. And then alternative results sometimes can be hidden. I've reviewed papers in which they had data presented, but they didn't analyze it, they didn't talk about it, but they put it in the paper, and it refuted some of the conclusions that they made, and they don't mention it. And I usually call that out. I mean, you got to mention it. Doesn't mean that you throw away the whole study, but there's aspects of that study that call it into question. I think it's important to recognize that and to admit that. And then, like I said, adhering to standards helps minimize bias. All right. So, all right, let me move on. Okay, I'm gonna put in some spurious relationships. When you're looking at association, even if those relationships seems to be in lockstep. It's not always true. And so people will look at different types of associations that in reality are probably not associated, just happen to be that the data matches up. And so I put a couple of spurious relationships in here because you got to be really careful about that as well. Is that here's the I just put a few here. Is that more physicians in the community, the more chocolate that is eaten. I'm not sure there's actually an association with the physicians in community and chocolate eaten. The divorce rate in Maine correlates with margarine sales. There's probably not a relationship there. I guess if you're divorced and you're making less money and you buy margarine instead of butter, maybe you can make an argument there. But other than that, there's probably not a correlation. The more sour cream that's eaten, the more motorcycle deaths. The more stork nests being built, the more babies being born. And my favorite, the older Miss America is, the more likely you are to die by a hot poker. And if you look at this, the graphs, here are the graphs on a timeline of dying by a hot item and the age of Miss America. And you can see it is almost in lockstep. But I am willing to bet there's really no true relationship with the age of Miss America and whether you're dying by a hot instrument. So next thing I want to talk about is sometimes you do studies and you find things that you didn't find results that you didn't really plan on. And this is looking at implementation of masks and social distancing with COVID. Now, there's been a lot of debate about whether masks and social distancing really helped with COVID because there was still a huge amount of COVID. There's still a huge amount of deaths associated with COVID. And did we go through all this stuff and really not have an effect given how prevalent COVID was and how many deaths we still had? So if you look at the flu data during this period of time, there's been a marked difference. Now, if you look at the Minnesota flu, so this is Minnesota flu numbers from 2019, 2020. That's just when COVID started kicking in. If you remember, COVID kicked in the late winter, early spring of 2020. That year, the flu that was out there was H1N1. If you remember, that was a particularly deadly virus. And it was the same one they called the Spanish flu, which was the previous worldwide pandemic we had, was H1N1. And I remember on the rehab unit, we had 4 adolescents that were on ventilators because of the flu. Now, they ultimately did very well and came off the ventilators, but we had 4 on the unit with ventilators and the flu. In Minnesota, the hospitalizations for flu that year were 4,000, and the number of deaths were 197. Now, this ended up being an average year for hospitalizations and deaths. It usually varies between 100 and 250 on deaths and hospitalizations similar, give or take 1,000 or so. The next year, when we implemented masks and social distancing, it was really non-existent. It's unprecedented how low our flu problem was. And the hospitalizations went down to 35% and the deaths were 7. So that's a huge, huge difference. So we can argue that masks and social distancing may not have worked, but when you look at the data on flus, it had a huge impact on that. And so when you look at this kind of stuff, you can look at when you have numbers that are so different from year to year, it's really hard not to associate the changes that were made with social distancing and masking and to attribute that to some of the decrease that we saw. And the jury's still out on a lot of it. I think that there are a lot of people that believe that it still helped and it would have been much worse. To give you an example, in the worst era of the COVID, so the worst period of the COVID, Minnesota was having 70 deaths a day. And so with in a whole season, they had 7 deaths from the flu, but they were having 70 deaths a day during the worst months of COVID. All right. Now, because of the heterogeneity of cerebral palsy and all the different treatments that are out there, there have been different groups that have come together to try to see what studies we should consider or what treatments we consider as good, valid treatments and should be implemented and which ones we should not. And so Novak and her group did a systematic review back in 2020, and they came up with what's called Traffic's Light of CP. And I would encourage everybody to kind of look at this because this is one of the best studies that's out there on looking at the various different treatments and the evidence that's out there whether it should be utilized or not. And so if they concluded as a group that there was enough evidence out there and enough professional consent about a particular treatment, then they would give it a green light. If they were kind of, yeah, we probably could, but you should be cautionary. We're not sure. We can't say it with a great deal of surety. Then they get it, probably do it. And then they did, and then the threshold below that would be probably not do it. And then don't do it was the ones that had the lowest level of evidence, and they didn't think they should consider it. And so some of these treatments that we consider mainstays really didn't have a whole lot of green lights. There are very, very few things that we had green lights that they thought had enough evidence to say definitely do it. And I'm going to present a couple of these different treatments. All right, CIMT. So I think CIMT, it's constraint-induced movement therapy. It's basically if you have unilateral cerebral palsy, you will restrict the movements of one limb or the less involved limb to facilitate the movements of the involved limb and have them involved in lots of different therapies. And then you also have them involved in bimanual therapy to use both hands together. Now, they gave this a green light because they thought that there was adequate evidence that was out there. And so this study here, this is just one of the studies that looks at the various different treatments. It looked at all ambulatory children with, well, looked at a group that was ambulatory that had unilateral cerebral palsy, and they got therapies, and they all participated in baby CIMT, so less than a year of age. And they had 30 minutes a day for 6 weeks on and 6 weeks off. And then they looked at 41 that did not receive CIMT, and then they did assessment, the assisting hand assessment at 2 years of age to see what differences there may be. And what they found is that there's a significantly higher group that tested in the high group in the baby CIMT versus the no baby CIMT. But if you delve into this a little bit more, what you also find is that there was more in the very low range than there was in the no baby CIMT. Now, there was a lot more of the very low in the CIMT, but if you take the low, which means you have a fairly low functioning limb, it was slightly more in the baby CIMT. But because the plurality of this study showed that there was more functional use in the baby CIMT group than the no baby CIMT group, and they try to match those carefully, they concluded that it does have some efficacy. And now, when they did the assisting hand assessment, they did that with a therapist at 2 years of age, going through in a controlled setting in a therapy area to test the babies to see how well they could use that affected limb. All right. So here's another study. In this study, remember CIMT is considered to be get a green light. Here's another study looking at accelerometer measurements to indicate arm movement in children with cerebral palsy. And what they found is that they test in therapy and out of therapy after CIMT quite high. So these children that went through the protocol of CIMT did better. But when they looked at these children 4 weeks after they finished CIMT and looked to see how much they utilize their affected limb in day-to-day activities, it was really no different than it was before. So these children, when you test them, tested better, so the limb could move better. But when you look at how much they incorporated into their everyday life, they weren't doing it any more than they had been before. So then the question is, okay, you can do CIMT, you can get it so that it improves the use of that limb, but if they're not going to use it anymore in their day-to-day activities, is it really improving their overall function or not? Now, my bias, and this is a bias, my bias is actually if it does improve, if they don't use it any more than they did before, but when they do use it, they have a higher quality of movement and they're able to do two-handed tasks more easily, I think that's a justification to do the treatment and to improve things, because their two-handed activities is probably a little bit better than they would have been before, even if they don't incorporate it anymore. Because kids can get really, really good, or anybody can, really, really good at using one limb if you don't have a function of the other limb. But that just shows that, initially this looks like you had a lot of good positive effects, which I think is true. And then, but that when it comes down to the everyday aspects, they didn't utilize it any more than they did before. So, all right, botulinum toxin. So recently there's been a lot of talk about botulinum toxins in whether it's been controversial or not. It's been in the pediatric literature. There's not as much debate in the adult literature, to be honest with you, or in the adult societies. But there is more so in the pediatric groups. People saying that botulinum toxins damage muscle and it doesn't have as much efficacy as the studies show, and that there's no long-term studies that show that it actually makes a big difference, that it's only short-term, and that's all true. But it doesn't mean the opposite, like I said, that if you don't have long-term studies, doesn't mean long-term it doesn't improve things, it just means we just don't have the information. So here's a study, and I was involved in this study, looking at using avobotulinum, which is Dysport, and this was a placebo-controlled trial. And so it's the highest level of intervention, and it showed significant improvement. Now, that placebo worked. Remember, the placebo worked, but the real stuff worked significantly better than the placebo did. Looking at the goal attainment scale, which is basically the treating is actually a therapist and the physician together with the patients, coming together with goals, specific goals. And I'm not going to go over the goal attainment scale. That's a whole new talk. But it showed that the modified Ashworth scale was significantly reduced, and they did have functional improvements. So the goals did improve relative to placebo. And so this is what the FDA used, these studies used to approve the use of Dysport. And again, they've got for botulinum toxin and physiotherapy for gross motor and walking, they gave it probably would do it. And they give a green light for just decreasing spasticity with botulinum toxin in general. So that group, the triphylites, felt that botulinum toxins does reduce spasticity, but when it comes to improving function, is a little more of a cautionary note and probably do it because the evidence is a little softer. Although this here shows that it actually is quite effective. Now, some people may have seen some of these studies looking at rabbits and botulinum toxin. And what they have shown is that, and the way botulinum toxins work is that blocks the release of the neuromuscular junction. So it essentially denervates the muscle, keeps the signal from the nerve getting to the muscle. And so then the muscle is temporarily denervated, and it will tend to atrophy and then develop some scar tissue and some fatty tissue within the muscle. And this is a rabbit that got injected by very high doses of botulinum toxin very frequently in a relatively immobile rabbit over 6 months. And if you look at all these pock marks, see all that white here? That's all scarring that occurred within the muscle. And this is the other leg. So this is the one side, and this is the other side. And this stays nice and pink and red. And so that looks like good, healthy muscle. But over a period of 6 months, after you stop using the botulinum toxin, the muscle has a great ability to recover. And after 6 months, it is almost back to its normal level. And within a year, it's very, very hard to tell the difference between the two. And so there's the muscle has a very good ability to recover. And so a lot of people will put out these studies saying, look, this is all the scarring that you see. But when you did the rabbit study, they used extremely high doses, more so than you would clinically. They did it much more frequently than you do clinically. And even after 6 months, it was starting to improve. And so there's really little evidence that it causes any long-term damage, at least in the animal model. All right. Now, Cott in Belgium, she looked at a human model. She looked at children that had botulinum toxin, and she compared them to children with cerebral palsy that had no injections to the typically developing children. And she looked at ambulatory kids that had injections into the gastrocnemius muscle, and they were followed for a year and had a biopsy after a year, and then she looked at the muscle. And so she was trying to answer this question: does there have long-term detrimental effects from botulinum toxin on the muscle itself? So what they found was the cerebral palsy muscle, with and without botulinum toxin, is abnormal, and there's smaller fibers and they're stiffer. That the injected muscle initially was smaller than then increased in size. And so what they found was that it actually improved the growth of muscle, and the injected muscles had better growth than the non-injected muscle at 1 year. It also had higher levels of fetal myosin, which is an indicator of regeneration, and that helps increase the growth of spastic muscles. So by decreasing the spasticity, the muscle starts to gear up and release more fetal myosin, which improves the growth. So there was no change in fiber size, but increased muscle fiber variability, which is good. And overall, there's little damage at 1 year and some improved growth. And so what she found was actually there weren't any detrimental effects a year later, that actually the muscle actually looks a little bit better. And there's some initial atrophy, but it recovers and seems to grow a little bit better. So she's in the process of doing more studies of that. But so far, it doesn't look like there's long-term consequences of botulinum toxin on muscle in children with cerebral palsy, and it actually might have, and this is very preliminary, but might have some beneficial effects on growth itself. All right. There was another study that looked at whether there was some functional improvements in using the gross motor functional measure with botulinum toxins, and looking at physical therapy and injections. And they looked at patients 12 weeks later and 24 weeks later. And what they found was that the group that got therapy only did no differently than the botulinum toxin group in therapy. And so there was no improvement in the botulinum toxin group, and then compared to baseline. And so they concluded that there was no evidence that functional improvements occur with botulinum toxin. But this was a therapy that was 3 times a week for a 12-week period of time. What they failed to mention in that study, even though they presented the data, is that neither group got better. It wasn't that the botulinum toxin group got the same amount of improvement as the no botulinum toxin group. Neither group improved. And so they didn't talk about, does therapy help? They talked about that botulinum toxin doesn't add anything, but they didn't mention in the study whether therapy helps, because after 12 weeks of getting 3 times a week therapy, their gross motor functional measure did not improve in either group. And so then you could argue, well, therapy doesn't work either. Now, I think all of us would say that the mainstay of treatment for cerebral palsy is therapy, because it does benefit the kids, and I firmly believe that. But in this study, it didn't show that. So then you got to question, why didn't it? Maybe the measure was the gross motor functional measure was not a good measure until looking at that. And then what they said also was that you saved 2,000 euros by not having the botulinum toxin, but what they also didn't mention is it costs 4,000 for the therapy. So the therapy is actually more expensive than the botulinum toxin. So in this study, my conclusion is that it doesn't really show anything. We have to do more studies to figure out where we are. I can't say for sure that botulinum toxin therapies work really well. And the Novak's group said that it probably would do it, and it wasn't a green light, it was just a yellow light. All right. Let me, because I'm running a tiny bit low on time. I will say that in this study here, looking at Sommerfeld and Hinsinger, I'm just going to mention this from 1981. Hinsinger, and you might be familiar with the Hinsinger collar. He was a pediatric orthopedic surgeon at the University of Michigan. And he's the one that designed the collars for the football team, and also designed it for the kids as well to help with neck injuries. And then he helped it for support for the kids. So that's where the Hinsinger collar comes from. Anyways, he looked at 19 students from ages 3 to 22 with severe cognitive and motor impairments. He divided the groups into 3 groups. Physical therapy got 30 minutes 2 times a week, and supervised physical therapy 30 minutes 2 times a week, and no physical therapy. And he looked at, and this was conducted over a 6-month period of time. He looked at postural control, range of motion, both back techniques. And just to let you know that goal-directed training is considered a green light with the Novak study. And what he found was there's no improvement nor differences in the groups. And what he concluded is physical therapy has no benefit in cerebral palsy. And he truly did that. I mean, I did clinics with him because I did my fellowship in Michigan. He truly would say that there's really no evidence that physical therapy is of benefit. And he felt that surgery was only benefit. He failed to mention there's a lot of good, there's not very good studies on that either. And there are lots and lots of problems with this study. When you look at these, how they divided, the kids that had severe cognitive and motor impairments, their ability to improve was very, very limited. And so you could just start there. But it went through a whole lot of different, if you tease this out. And so again, when you look at this and you look at the conclusion, you would come up with there's no difference, but if you delve into the article, you can see a lot of weaknesses that are in there. All right. Conductive ed. So there's been this one, I think it's probably don't do it. It's yellow, but it's just below the line. You see the line right there? You can see the dotted line. It's just below the line. So Novak said probably don't do it. And that's just because of evidence. That doesn't mean it doesn't help. It means that they didn't have any evidence to say you probably should do it. But conductive ed is originated in Hungary, for those who are familiar with it. It treats motor and functional improvements, and it actually advocates for improving cognitive function as well. And they have various different modalities, and they look at various aggressive physical activities, music, peer interactions. They have a conductor that's encouraging, and they have specialized pieces of equipment. And very, very intense. So it's several hours a day over several weeks. And it works to improve function, communication, and self-esteem. And it believes that it improves neuroplasticity. And I would argue that repetition actually does help. Whether this helps using the specific methods that they do more so than traditional methods, I'm not sure about, because I don't think we have any good evidence of that. But I think we do have some evidence that repetition in general does help. And so there's not a great deal of evidence that conductive education helps. But in my mind, if you can get kids to participate in activities and do it repetitively, you will see improvements. And if conductive ed is the best way to do it, because that's what engages them the best, I say go for it. If it's regular traditional physical therapy, I would say go for that too. I think the key here is that you want to do repetition in goal-directed activities, and I think that's the key. All right. So there's a study in 1998 looking at two groups of children divided into conductive ed and traditional therapy, and they got the equal amount, and they saw no significant difference between the groups. I got the conclusion ahead of time, and that's why Novak is saying that probably don't do it. It's not necessary that you wouldn't do the conductive ed, but just not. You don't necessarily need to use that technique, but it's really just important to do the repetition, like I said. All right, AFOs. Now, there's been studies looking at ankle foot orthoses, or AFOs, and they vary greatly in which type is best and which type isn't best. And there's a systematic review of AFOs, and there's strong evidence of small improvement in gait speed and small effect in gross motor function, strong evidence of improved foot position and equinus gait, but no significant evidence of which type works best, and no evidence that it helps ADLs. And then the gait lab evidence can be very different from real life experience, because gait lab's on a flat surface on a straight line, and that's rarely real life. And so the evidence of improving function with an AFO is very, very limited. It's very small. And so it's probably would do it in Novak's criteria. But the evidence that we have on systemic reviews is that it's fairly limited. Now, I would guess that most of you use AFOs, but I would tell you that I don't get hyped up as much as I used to in my younger years. If they're miserable with AFOs and we can't really tell that much difference when they're walking, then I don't worry about it. But I do think that AFOs, if they're helping improve some level of function in your patient, and they're helping control their foot and prevent contractures and worsening the foot, then I think that they're a valid treatment. With that being said, the vast majority of my patients are in AFOs, and I'm prescribing them all the time. So here's a study looking at a particular group, looking at a particular style of AFOs, and this is a style that Lane Owens has looked at, and it looks at she has an emphasis on shank angle to the floor in a solid ankle AFO with the dorsal wraps, has an inner liner, and has a heel to bring the foot forward and to optimize the foot position. And there's a group that of practitioners that feel that these are the most ideal braces and that they work best, and then we use them for just about everybody. And I will tell you that the evidence for this is very limited. There's no controlled trials looking at this, but in fairness, there's no really good controlled trials with any type of brace that is very definitive. And so I would say that when you're using this particular type of brace, if you have a patient that seems to do best with it, then go for it. But it's not necessarily a brace for everybody. And you have to really pick and choose which patients will do best with this particular brace. Now, if anecdotally, I can tell you that from my experience in patients that have a significant amount of motor impairment and spasticity and walk with assistive devices like a walker, sometimes it's very difficult to control their ankles, and these kind of braces actually work quite well. In the patients that are pretty high functioning, I think that they can be a hindrance, particularly going up and down steps in other areas. All right. Last slide. Close to the last slide. Yeah. I want to briefly touch on the ones they said don't do it. So these are the traffic lights that were red, and they felt that there really wasn't any good evidence that these particular interventions were valid. Actually, they put sensory integration in here for improving motor skills. Hyperbaric oxygen, I think there's been a lot of studies that looked at that and haven't shown significant improvements in function with hyperbaric oxygen, but it's still out there and it's still being utilized and it's very expensive. NDT treatment, so neurodevelopment treatment, but this is no passive form. This is not the one where it'd be goal directed and looking at some of the variants of the NDT, but this is the original form where you passively were moved in certain movements and you couldn't progress until you mastered a certain skill and moved up to the next one. They found that there's no real good evidence for that. And then cranial osteopathy for gross motor skills. And so they had put cautionary notes for those. Now, there have been studies out there that don't show any significant difference with those. Now, as I've said, that doesn't necessarily prove the negative, but if you get a huge collection of studies that does, and the bigger this circle is, means the more trials that have been done, randomized controlled trials that didn't show efficacy, then the more valid that conclusion may be. So, all right. So again, for those of you who are interested, I would recommend that you pull the startle and look at all the different traffic lights. And you'll be surprised at which ones show up. The surgery one, where's the symbol? Symbols is in here, right here. This is symbol. This is the orthopedic surgery. You can see this is probably would do it. They don't even, in this one, there's really not good evidence that orthopedic surgeries to improve gait is above and is definitive. Even with all the gait analysis work that has been done. So even that didn't even get a green light. So it's a pretty high bar to reach some of these. But again, I would caution you that I think most of us do most of these yellow lights, and you just have to pick and choose your patients really carefully to see if they benefit or not. And again, these yellow lights doesn't necessarily mean that they don't work. It just means we just don't have enough evidence to get it, bump it up to the green light, at least in Novak and their group's mind. All right. So conclusions. Not much is for sure with treating cerebral palsy. It's clear as mud, as we like to say. It's very difficult to conduct high quality studies given the heterogeneity of CP. Goal-directed studies are the most appropriate. You need to involve the patient and families in setting goals in therapy. Again, you want to be able to treat what's most important to the families and the patient themselves. You want to use appropriate adaptive bracing equipment. Getting your reps in is very important. I think that there's no substitute for that. If you're trying to improve walking, the more walking you do, the better. Now, that doesn't mean you can't use other modalities and other ways of getting there, but repetition always helps, as long as you're not overdoing it. And different techniques usually have similar results, if similar intensity, and that goes back to the conductive ed and the standard PT. If you did the same amount of time doing each one of those therapies, they had equal efficacy and both of them improved. I always, I'm going to commonly say that, families is that when they ask, they're confused because they're getting confusing information from various different specialists. I tell them, I say, if you ask 5 physicians and therapists or anybody else or any other care provider the same question, you're going to get 10 different answers. And there have been a lot of champion teams that have won championships with coaches that had different styles of play. And so you can still get there and you can still be a champion by doing different techniques. But you just have to make sure that the one that you're implementing is efficacious. So, all right. That is it. And I guess we can take some questions if anybody has any questions. I apologize for being all over the place with that talk. I was just trying to illustrate just a potpourri of information that's out there regarding cerebral palsy, and it's oftentimes very, very confusing and difficult. Don't get too hyped out about one study showing one thing or another. You just got to delve into it and look at it and be pretty critical about whether you think it's going to help you in your practice or not. And but be diligent about these treatments and doing your best to do evidence-based treatment, because even though it's difficult to do studies in the group, is a lot of information out there, and it will give you some insights. I think it's important as we move forward. And that traffic light study, I think, is particularly helpful.
All right. Thank you so much, Dr. Gormley. And as you said, that was a lot of information to digest. We do have a few questions that have come in, and I will start with, in real life, isn't everything above 90% high probability? And why is it different with the p-value? Do you have a comment?
Well, I guess if I'm interpreting the question is that everything like above 90%. When you look at these studies, you have to reach scientific criteria. You want to be doubly sure it's not a spurious or a random association. And so there are some different areas of scientific study where they'll look at 90% as a cutoff. So the p-value would be 0.1. So it would be 90%. And if you look at law is, if you're in a trial, it's just more likely than not. So that criteria is it's 50 plus 1. It's just barely above 50%. And I don't think that's nearly enough for a scientific study. And so if we're going to make any kind of conclusions, I think it's important that we have a very, very high standard. And 95% assurity is really what we've kind of picked and settled on. And that's just the commonality. There are a lot of people getting away from the p-value, though, because they don't feel that is a good way of looking at things, to be 95% sure statistically.
All right.
So
we have a question from Christine, and just a reminder, everyone, do put your questions in the Q&A, and you can find that button on the bottom toolbar. We have a question from Christine who says, where does SDR fall in the red, yellow, and green lights?
Oh, if you looked, SDR is in the probable, it's in yellow.
All right. Perfect.
And I can go on about that. That would be a whole talk on SDR. I have some very strong feelings one way or the other in some of the studies and how they've been conducted.
That could be a whole nother presentation.
That'd be a whole presentation. I'm actually a fan in certain patients of an SDR. I'm also very particular about doing conservative FCR, not very much cutting. And so that's my bias.
Wonderful.
But it's a probably.
All right. Look for that in the future, everyone. And a question from Katie. Are you aware of any studies that look at the benefit of AFOs with non-ambulatory patients? As an OT, teaching these kids to put on those braces is such a difficult task. It's a burden to caregivers and presents a risk of skin breakdown. Are they really worth it?
I like that question. It is, and it seems like I'm in the same camp as you are. It's I tell families all the time, it's you don't want the treatment to worsen the disease. You want it to be helpful. And so a brace, let's take, if you're an OT, you've got wrist orthosis, you're trying to get them on there. You want to keep their hand in a functional position. Well, if their hand is not very functional at all, you want to keep it maybe from getting stuck like this and all fisted because it's hard to dress and then the skin breaks down and stuff like that. However, if putting a brace on is miserable for the child, it's miserable for the family, they can't keep it in there and they have to do it all the time. And to have any kind of results, they have to wear it either all night long or half the day. And then they got to stretch them all the time and everybody's miserable. And having the hand like this is not that much different in their care's position and comfort and just their quality of life than having it like this, then don't worry about it. And it's the same with the foot. If you have somebody that's non-ambulatory, I've got a ton of kids. I just had a kid today. It's got a spinal cord injury, been in AFOs, had some sores on their heels, and so they got to get them corrected. And they kept getting sores, and then we adjusted the brace and kept getting sores. Finally, just said just forget the brace, and they have no sores. The sores went away. They don't have spasticity, so it's one of those kids with a spinal cord injury that has low tone, and their feet look great. And then they're in a standard 40 minutes a day, and they tolerate it just fine. So we're not doing braces. So I think it's to your point. Each patient's a little bit different, and I think there is some validity in not wearing braces. If you take this, let's take the Duchenne muscular dystrophy patient. Duchenne muscular dystrophy, 100% of them will get horrible clinus deformities if you don't wear braces. If they wear the braces at night, they will maintain 90 degrees if they do it religiously. But about half my patients choose to do that, and half of them don't. And that's because it's just miserable when they do. And ultimately, long-term for their life, their foot being down like this doesn't make that much difference. And it certainly doesn't, it's certainly no worse than not being able to sleep for years on end.
Awesome. How would you answer this one? Why is goal-directed therapy so important?
Well, yeah, yeah. If you have goal-directed therapies, that means that you are picking a certain skill that you're working towards specifically, and it's not generic. And so you want that to translate into your everyday life. And so if you're picking a goal with the family and the patient, it is something that's important to their life, and you're likely to have an impact on their life, whether it be functional or care's position of comfort or some aspect of their life. And so that's what the importance of goal direction is. It's because it's going to produce improve some level of functionality. If to use an analogy you just talked about, if your goal is just to improve hand position and it doesn't really make any difference from a functional standpoint or their ankle position, then you're doing a whole lot of stuff that's really not adding a whole lot to their quality of life. So goal directed is really picking something that's important to them, and that's why it's important.
Perfect. One more here. What is the difference between scoping review and systematic review?
A retrospective review or scoping?
The question was, to me, was scoping review. I don't know. Valerie, do you want to chime in? Scoping. She's doing scoping. Scoping review and systematic review.
Sure.
Yeah.
Sure. Hold on for a second. I'm jumping on. Hold on. Gotta find my camera. Oops.
I don't know. I'd have to look that one up.
I think of the difference between a systematic review and a scoping review. I think systematic is a little more comprehensive. I think it's more rigorous. Whereas a scoping review may not have the full rigor, but it's more a broader perspective. So it takes into, for example, maybe some studies that would be yellow lighted in the traffic lights. So it's a little more, and so that's why I think of it as being just more of like a broader view of what's that can contribute to our understanding. Does that make sense? Am I right, Mark?
I'm going to go with you. I'm not going to argue with you.
I love it when you agree.
Yeah.
All right. And I love the traffic lights. We have another traffic light question. Where does the tendon lengthening surgeries fall in the traffic light?
That would be all right. So there's two sets of traffic lights for the tendon lengthening. There's one in the functionality improvement, and that's in the probably would do it. So it's yellow. And then in the traffic lights for improves musculoskeletal deformities, it's in the green light.
Okay.
And so there's two different things. So what that means is that you can change where the position of the foot is, because that's what you do with tendon lengthenings. But it doesn't necessarily improve functionality. Now, there are some, and it depends on what your definition of tendon lengthenings is. There are certain treatments, and this may be what you're getting at, where you do percutaneous tendon lengthenings, where you go and you snip the hamstring tendon and the gastroc tendon and the hip flexor tendon, the adductor tendon, and that loosens all of those muscles up temporarily. That will improve the range of motion and can improve some function, but there's no evidence, there's not a lot of good evidence that improves functionality. And so if that's the particular one that you're looking at, that would be I don't know if they looked at it, but that's probably below the line and it probably wouldn't do it. I wouldn't put it in the red, but it's probably wouldn't. And that's because of lack of evidence that it has any long benefits.
Okay, great. If that did not answer your question, please add a backup
Please,
to the Q&A here. But I do have another one. At the Function for Life and Pediatrics Conference at the University of Virginia in 2023, Dr. I may get this wrong, Tabaie, Tabaie, from Children's National in Washington, D.C., said that repeated Botox injections did indeed damage muscles of children with CP. What do you say?
Well, I think temporarily it always does, and that's the role of botulinum toxin is to denervate the muscle, and so temporarily it does decrease size of the muscle, and you can see some fatty infiltrates that do occur. Long term, it doesn't have any deleterious effects, and there's certainly no evidence of that. And the evidence that we do have, which is relatively recent, is that it might actually help improve growth of the muscle more so than it's letting the spasticity sit. And so all this hullabaloo you hear about damaging muscle long term, and look at these rabbit studies, that stuff is not valid. I'm pretty strong about that. Whether it actually improves the growth of the muscle to a significant degree, I think the jury's still out on that, but the preliminary information that it does. And I would caution you, for botulinum toxin, if you have a group of providers that do botulinum toxin injections and their patients seem to get better, and you're following those patients, whether you're a provider, a therapist, or a physician, or if they seem like that your patients are doing better and doing a good job, then I think that they're doing a good job. I would not worry about the long-term consequences of damage to the muscle.
Okay. Hopefully that answered your question.
I think the bigger question,
she did piggyback
honest,
that it was long-term, not temporary. So,
yeah,
but I think you answered that. Yeah.
Yeah, it's long-term. I think the bigger question of that is that how much you should do botulinum toxin injection, how often should you do it, and for how long you should do it from a functional standpoint. And I think that's you have to look at that very, very critically. I think if you were to stop it because you're worried about long-term consequences of the muscle, but it was still benefiting the patient functionally, I tell you keep doing it functionally, because it's the deleterious effects on the muscle are not going to be there long-term. But the muscles get stiffer over time. Botulinum toxin you develop resistance to. There are other things. The spasticity can decrease over time as someone gets older. All of those reasons would tell you to stop doing the botulinum toxin, but then I wouldn't do it because of long-term damage.
Perfect. Thank you. Is there any study that says pitching an AFO is better than a normal AFO for CP kids?
No, and that gets back to the Owen study, that the Owen brace that I was talking about, Elaine Owen. In certain patients, pitching that brace and getting that shank forward really does benefit them, and it does help. It unlocks their knee, makes it easier to move, it improves the fluidity of the gait. And I think that that's actually a fairly small group of patients where that particular brace causes significant improvement. And then you can also do that. You don't have to use the full-blown version of that brace and just put a heel on it and bring that shank, a tibial shank forward, and it will cause you to bend your knee more. And so you have less genu recurvatum. It's easier to advance the knee. And so you got to play with it. So there's not a lot of good evidence that universally that helps. There is some evidence that in certain patients that have particular issues, with getting their tibia shank tilted forward, that it does benefit. And so it's really a case by case.
All right. This is going to go back to this is probably more of a comment, and I'm going to let you react. Repeated injections for year after year do not permit the muscle to recover. Histological studies on kids with CP are rare.
That's very true. I can't argue with that, and I would say that they're right. I would say that the information that we have so far is that it doesn't cause significant adverse changes above and beyond what cerebral palsy muscle would, because that does cause chronic changes. If you were to do, let's say, do injections every 3 months at very high doses repetitively for 10 years, you probably would get some atrophy of that muscle that would be hard to recover from. I think that they ultimately would, but probably at that point, the muscle would be pretty scarred up. And so I would say there's some validity to that at that level. However, if you are to look at patients very carefully and you repeat the injections as the effect of the injections are wearing off, you keep the muscle as supple as you can. You can do that for a number of years and it'd be okay. I didn't show videos here, but I've got patients that I've injected for 25 years, and I've got one particular patient I've injected for 30 years. I'm old. In 30 years, every 4 months, and she's obviously an adult now. Well, she was an adult when I started, actually. She looks way better now, 30 years later, than she did. And I got videotapes before she started. And that muscle, when I inject it, every time because I do this all the time, I stick a needle in the muscle. If I can hear really normal muscle activity, because the EMG needle, I can hear whether the muscle is abnormal or not. There are certain sounds that an abnormal muscle makes, and it's very rare that you hear the abnormal sounds, and you almost always hear normal muscle. And so if there is normal sounding muscle in reactivity, that muscle, at least there's certain segments of the muscle that's very, very normal. And you would think that if you injected them that much over that period of time, all of that would go away. It does not. And it's still effective. Now, maybe not be as effective as it was from day one, because you may have a little bit of resistance, but you don't see that long-term stuff.
Wow, it's amazing. All right, here's one from an individual, sorry. As a 40-year-old with spastic cerebral palsy, I've undergone multiple leg surgeries, including 2 hamstring releases and a heel cord release. These procedures have improved my leg movement. The hamstring releases were done before I turned 19, and I am now 40. Additionally, I had a rhizotomy at age 3, which helped my balance. I would strongly support the hamstring release, but I'm not sure about the heel cord.
I would concur. And there's a caveat to that, and I'm glad that the hamstring worked out really well. Hamstrings tend to be, for kids with cerebral palsy, tend to be a really big problem. And if you overdo the heel cord release, you can decrease your power and your push off. And that's one of the reasons why I'm an advocate of rhizotomy, but I'm an advocate of conservative rhizotomies, particularly when it's down with your plantar flexors, because you can make a kid who's 3 or 4 and has a rhizotomy look really, really good at first. But as they get older, if they don't have that power generation and their ankles to push off, they'll crouch down. And that's what a heel cord release does, is that if it gets rid of some of that power generation, and if you do it too much and you don't have enough power generation, then you tend to crouch down because you can't push back and you can't straighten out your knee. Your hamstring wants to bend that knee in kids with cerebral palsy and adults too. And you want that to be loose. And whether that's with a rhizotomy or doing releases, if you can get it to stay, the hamstring is notorious for getting tight over time and reeling itself back in. And so it's really hard to keep it. So I'm really glad that they had to have it twice, but I'm really glad that at least the second time it seemed to take and it had some long-term effects. And so I would tell you that, yeah, keeping your hamstring loose is very, very important. And I would say not overdoing it at the ankle is very important, because you don't want to lose too much power. So I think you're actually articulate what I would say we see in general.
Perfect. Okay, comment. Cerebral palsy integrated pathway. Any comments? I don't know what that means.
No, Valerie, you want to take that one?
You're throwing me off here.
I know.
I would need more of a definite. I'm not sure what integrated pathway means.
I don't actually know either. So I'm thinking of the care pathways. Maybe they could give us a little more insight into what they're calling integrated.
Yeah,
Thinking of the
I, yeah.
different care
The person
pathways.
asked that, can
I
you
don't
be,
have a first name.
Yeah,
but
But
whoever,
if
if
this
they're
person
listening,
wants to elaborate, they please
yeah,
do.
I think so. Mhm.
what integrated pathways mean specifically.
Yeah, we'll come back if they
We'll
can.
come back. Yep.
Okay, I'll be honest, I'm not real good at terms. So if you can throw out some of these things, if you describe them to me, I can give you a comment. But a lot of times I don't know them by name. It's just
And I'm
not.
have no help with that one. So
Well,
I'm going
it's
to go
not.
on to the next
That's one of my
question.
weaknesses. I mean, I can't remember names for anything or anybody.
Okay, where does stretching fall in the traffic lights? We have a few doctors on our area that just recommend stretching instead of 24-hour positioning or even surgery.
Yeah, I I don't think there's any one thing that you should put all your eggs in one basket. The stretching is extremely important. I cannot uh uh emphasize that enough. I'll give you a quick story. I had a patient discharged from had a bad brain injury, discharged from Gillette, went up north into a rural area. They didn't have any pediatric kind of care facilities. They had an adult facility. So this kid was in a nursing home, in an adult nursing home, because that's all they had. And he was horribly, when he left, he was horribly spastic. Just muscles were crazy spastic. And he came back for a follow-up 4 months later, and muscles were still really spastic, but I could stretch everything. It was moving all over the place. I'm like, oh my gosh, this kid's range of motion is awesome. And we did the visit, and they were getting ready to leave. And finally, one of the caregivers was with him because, Dr. Coleman, do we have to do the stretching every 2 hours while he's asleep? And I said, what do you mean? He goes, well, we do 10 minutes of stretching every 2 hours, and we're doing it while he's asleep. Can we not wake him up and let him sleep at night and just do it during the day? And I'm like, let me get this straight. For the last 4 months, you've been stretching him for 10 minutes every 2 hours, 24 hours a day. And they go, yeah, that's what the order says. I'm like, oh my gosh, we can't get anybody to do that. That kid was crazy loose. So it just taught me right there, then and there, that if you stretch enough, you can stretch out even the most spastic muscle. But whether it fits into your life or not is a different deal. So it does work, but I would do all these other measures too. We always talk about, there's a Venn diagram of what's the perfect types of treatments for kids, and they're always different and it's always evolving. And so I wouldn't say just stretching and no surgeries or nothing else. If you're trying to stretch and it's miserable and you're not getting anywhere, do surgery and hopefully that it lasts longer. And therapies are very important for all of that, even though it's a yellow light. Well, there are some green lights there too, but it was a mixed bag.
All right. Good. What are your thoughts on Botox and splinting for the upper extremity use function?
All right. I think if you're looking purely for position and reducing spasticity, it's really good. If you're looking to improve function, there's a happy medium there. So when we were doing the upper extremity, just to give you an example, when we were doing the upper extremity studies and doing the placebo stuff, what we found is that it significantly improved range of motion. It significantly improved their spasticity. It did not significantly improve the function of that limb. But when we did a deep dive and did what we call an ad hoc, so we basically go back and look at some of the other information that was out there, we found a subgroup of patients that had functional improvements. And when we looked at those patients, it ends up that they had less muscles injected and had lower doses that were injected. But their spasticity wasn't as reduced. And so there was a happy medium between doing too much, so you got a lot of improvement in spasticity and range of motion, to doing not too much and allowing some of that spasticity to be there, but their function was a little bit better. So you took the edge off, but not a whole lot. And so there is a balance there. So I think for range of motion and positioning and spasticity and comfort, it's good. If you're looking to improve function, you might have to sacrifice some of that and not dial it up, but dial it down a bit as far as how much you're injecting to get some functional improvements.
All right, I have two questions. I'm going to kind of read this one together because they're both from the same individual, but Kergram, I don't know if you know this person,
Very good friend of mine.
opposes any use of Botox, but says max one time a year if you cannot be persuaded to stop.
Yes.
And then what do you know about the use of hyaluronidase
Oh, yeah. Okay.
injections for
Yeah.
facial hydration?
Yeah. And that's just something that they use for Dupuytren's contractures, the same thing. You might see the advertisements of John Elway's kind of famous for that. The quarterback that was from Denver, he's got a bad one. In his, his fingers are stuck like this, and you inject it in here, and it reduces some of the contracture. It's basically, it reduces scar tissue, breaks up scar tissue that's in there, all that fibrous stuff. It breaks it up. So Kurt Graham. So Kurt Graham's a very good friend of mine. He's one of the grandfathers of cerebral palsy. He's certainly one of the grandfathers of pediatric orthopedic surgery for cerebral palsy. He's a great guy, very bright. He has a bee in his bonnet about botulinum toxin, and his biggest beef is it's used too much, and that if you use it too much, one, it gets you away from doing some other things that may be beneficial, whether it be surgeries or other interventions. And he thinks that you probably can get by with less injections than more injections. And I can't disagree with that stuff, with his analysis. Now, with that being said, I usually don't say once a year. Mine is twice a year. My average patient is probably 5 to 6 months. Every 5 to 6 months. It's very rare patients I have the 3 to 4 months. And then there are specific patients that fit into that category. And I'm not going to go into all the great details of that, but there's certain groups where I'll do that often. It's for various different reasons. But for the vast majority of my patients, I do it for every 5 to 6 months. As they get older, it's probably less. And so I'm somewhere in between the super aggressive injectors that he does not like, and then the super conservative injectors, which he is like once a year if you're going to do it. I think once a year, unless it's a very specific patient, I think once a year for most patients is not quite enough if they have a significant amount of spasticity. You got to hit it at least a couple of times a year. But I
We lost your sound,
Oh, you did?
or maybe it's on my end.
I don't know. Well, maybe somebody wanted me to shut up. And then the hyaluronidase, I can't really say that very well. It's just in its infancy. So we're just looking at that now. I think if you have patients that have like horrible hamstring contractures and they're fixed, and it's not just their knee, but it's actually their hamstring itself. It's not just a fixed knee flexion contracture. We could inject that muscle and hopefully loosen it up and allow it to release. And so people are starting to look at that right now. So we'll know probably in another 5 years or so what it's going to be doing.
Okay. I just had technical issues. Can you guys hear me? I couldn't
Yeah.
hear any of the last things you said. I don't know if my headset quit working or what happened, but so I don't know where that left off, but
Okay.
I am back. Let's see. So Michael has a comment. He says, I was the third rhizotomy in the country at the time, and it was very experimental back then. And I think he's just letting us know that. So he'll probably be very interested in your SDR presentation to come.
Yeah, yeah. How old's Michael? I'd love to know how old he was.
I'll see if he types something in here.
I'd love to know what he thinks, because the rhizotomies have evolved quite a bit over that period of time, and I have certain biases about the techniques and how you should do it. I'm just curious about how he thought whether he thought it was helpful or not, and how long ago that was. Because it's one of the things we don't have a lot of long-term data on is on rhizotomies. So we have some, and we have good studies that are out there, and some with some mixed results on it. But yeah, I think by and large, like I said, I wasn't a fan. I think by and large, the long-term effects look good. But it's not earth-shattering. It's not like, oh my gosh, we can be a complete total idiot not to do it. It's not that, and not to that level.
Right. He hasn't commented yet. So,
Okay, that's fine.
and we are down to just 3 minutes. So, thank you so much, Dr. Gormley, for this wealth of information and a great Q&A. And I just want to remind everyone, as Valerie mentioned in the beginning, that your feedback is very important to us. So please take a moment and scan the QR code to give us an evaluation for this evening. And then you will be receiving a certificate from the CME department at Gillette, and that should come in a few days. The recording for this presentation will be on the ucp.org site under, I believe it goes under the research tab. When you're at the top, you will find all of the past recordings from the professional learning series. And please mark your calendars and watch your emails for our next upcoming presentation on September 18th with Dr. Heather Feldner and Andrea Sabay. And that's on-time mobility. So again, thank you. Oh, wait, here. There's one more. We have one more minute. Do you do casting post-Botox?
Very often. If you have a significant contracture, I think it really does add a beneficial effect, and it makes the casting last longer. I mean, typically, if you just do the serial casting, it'll well, one, if you do just serial casting without decreasing spasticity, it stretches the tendon, doesn't do much for the muscle, so the muscle doesn't stretch or grow very much. If you decrease the spasticity in the muscle, and as the COT study showed, you can actually get some increased growth in some stretch, so you can maybe get a little bit of stretch in the muscle itself. But I think from a functional standpoint, you do much better because you start off with a better position of the muscle. So I use a lot of casting with injections, and if you do just casting, it's gonna be 6 weeks. You can be tight again, and with injections, you can hopefully get, like I said, 5 to 6 months out of it.
Wonderful. All right. That wraps it up for this evening. Thank you so much, everyone, for joining us, and Dr. Gormley, and we will see you in September.
Yep. All right.
Bye,
Thank
everyone.
you. I hope it helped. I hope it was good information. All right. Thanks.